Hey everyone, welcome back. Today we're doing the pericardium. I know, the pericardium doesn't exactly scream blockbuster, but trust me, this tiny 2-layer sac around your heart causes an enormous amount of chaos on step 2. Chest pain, shock, silent fluid buildup, a heart wearing a straitjacket. This thing has range. Let's get into it. This is our high-yield walkthrough of pericardial disease for USMLE Step 2 CK. 4 topics, 1 SAC. Acute pericarditis, tamponade, constriction, and, of course, the NBME traps hiding inside all 3. And if you remember nothing else today, remember this line: pericardium, tiny sac, huge drama. Because that's basically the whole lecture. Think of pericardial disease as a 3-lane highway. Lane 1, chest pain. Lane 2, shock. Lane 3, chronic right-sided heart failure. Every vignette you'll see today merges onto one of those 3 lanes. Your job is just to spot which lane you're in, fast. Let's speed run the patterns. Chest pain that's better leaning forward? That's acute pericarditis. Shock plus a sky-high jugular venous pressure? Cardiac tamponade. Ascites, edema, and a Kussmaul sign? Constrictive pericarditis. Regional ST elevation with crushing pain? That's a myocardial infarction, not vibes. And tearing pain with a pulse deficit between arms? Aortic dissection until proven otherwise. NBME Pearl right here. The first fork in the road is pain, pressure, or plumbing. Do not confuse them. Here's the master algorithm. Patient walks in with chest pain, dyspnea, hypotension, or right-sided failure. First question, always: are they unstable? Shock plus high JVP means you treat tamponade right now, no detours. If it's pleuritic or positional pain instead, get an ECG, troponin, and inflammatory markers. Effusion or an unclear picture? Echo. Chronic congestion with a preserved ejection fraction? Now you're teasing apart constriction versus restriction. And the golden rule underneath all of it: treat the syndrome first, go hunting for the cause once the high-risk features show up. Quick reference time: acute pericarditis, sharp pleuritic pain, better leaning forward, treat with NSAID or aspirin plus colchicine. Cardiac tamponade, hypotension, JVD, muffled heart sounds. That's urgent pericardiocentesis if unstable. Constrictive pericarditis, right heart failure, Kussmaul sign, a pericardial knock, diuretics, and pericardiectomy if it's chronic. Don't forget the imposters: a STEMI mimic with regional ST elevation and reciprocal changes needs the reperfusion pathway. And tearing pain with a pulse or blood pressure discrepancy is aortic dissection. CTA if stable, straight to surgery for a TABE A. Picture 3 hearts side by side. 1, inflamed. That's acute pericarditis. 2, fluid-filled, like a water balloon squeezing in. That's effusion, or tamponade if it's under pressure. 3, rigid and thickened, like the heart got shrink-wrapped. That's constrictive pericarditis. Same neighborhood, same little sac, but 3 very different emergencies, and 3 very different next steps. Chapter 2, Acute Pericarditis. The pericardium here is angry, scratchy, and very, very positional. It's basically the moodiest organ lining in the body. Picture your classic patient, a young adult just recovered from a viral illness, or maybe a few days out from an MI or cardiac surgery. They've got sharp pleuritic chest pain. It's worse lying flat, but leaning forward? Suddenly they feel so much better. On exam, you hear a pericardial friction rub, that classic scratchy to and fro sound. And the ECG shows diffuse, concave ST elevation with PR depression. NBME Pearl. If leaning forward helps, the pericardium is basically saying thank you. You need 2 out of 4 criteria to call this acute pericarditis. 1. Typical pain, pleuritic, positional, better leaning forward. 2. A friction rub, that scratchy triphasic sound, best heard leaning forward at end expiration. 3. ECG changes, diffuse ST elevation and PR depression, and importantly, not regional like a STEMI. And 4. A new or worsening effusion, which ECH will confirm. 2 of 4. That's your testing in. Let's zoom into the mechanism. Causes. Viral infection is the big one. Coxsackie, echovirus, even HIV. Plus idiopathic cases, post-MI Dressler syndrome, autoimmune disease like lupus or RA, uremia, malignancy, or after cardiac surgery. The mechanism is simple. Inflammation roughens the parietal and visceral pericardial layers, and they literally rub against each other. Ouch. The consequence? Sharp pleuritic chest pain, that telltale friction rub, and diffuse concave ST elevation with PR depression on ECG. Notice the PR depression, especially in lead 2. High-yield pearls. Pain is worst lying flat, better leaning forward. The rub shows up in maybe 30 to 50% of cases. Be careful with NSAIDs or anticoagulation if the cause is uremic or post-MI. And the big complication to watch for? Cardiac tamponade. Let's put pericarditis head-to-head with a STEMI, because this is exactly where Step 2 loves to trip people up. ST elevation, diffuse and concave in pericarditis versus regional and convex or straight in STEMI. PR depression, common in pericarditis, uncommon in STEMI. Reciprocal ST depression, usually absent in pericarditis except in a VR or V1, but common in a real STEMI. Q waves, pericarditis, no. STEMI, they may develop. Pain, pleuritic and positional in pericarditis, pressure-like and non-positional in STEMI. And troponin, normal or mildly up in pericarditis, but a clear rise and fall pattern in STEMI. Memorize this table. It will save you. Workup time. ECG first for that classic stable chest pain presentation. Troponin can be mildly elevated if there's myopericarditis, so don't panic immediately. CBC, ESR, and CRP support the inflammation story and help track your treatment response. Transthoracic echo checks for effusion, tamponade, and ventricular function. And cardiac MRI comes in when the diagnosis is unclear or you suspect myocardial involvement. NBME Pearl. Troponin alone does not separate pericarditis from a heart attack. Context wins every time. For a stable patient with classic acute pericarditis, NSAID or aspirin plus colchicine plus GI protection. Restrict exercise until symptoms and inflammatory markers improve. If this is post-MI, aspirin is preferred over other NSAIDs. And avoid routine steroids first line. That's how you activate the recurrence gremlin. If there's a high-risk feature anywhere in the picture, admit the patient and go looking for the underlying cause. Medication cheat sheet. Ibuprofen, your common first-line NSAID. Just add GI protection. Aspirin, the move for post-MI pericarditis, but avoid other NSAIDs early after an MI. Colchicine, add it to cut down recurrence, though you'll adjust or avoid it in severe renal or hepatic disease. And steroids, reserved for autoimmune disease or when NSAIDs and colchicine have failed. They are not, I repeat, not routine first line. How long do you run colchicine? First episode, 3 months to reduce recurrence. Recurrent pericarditis, 6 to 12 months for longer anti-inflammatory control. Renal or hepatic disease, dose adjust or avoid because of toxicity risk. And if there's severe diarrhea or signs of toxicity, hold it and reassess. Do not power through it. Here's a classic trap. Do not reflexively reach for prednisone first. Steroids actually increase the risk of recurrence. Save them for autoimmune disease or when NSAIDs and colchicine have already failed. And always exclude infection before you immunosuppress anyone. The pericardium remembers. It can be petty. NBME Pearl. Steroids are the break glass if needed option, not the opening move. Who gets admitted? Fever over 38 degrees Celsius. That raises suspicion for bacterial, TB, or systemic disease, so go search for a cause. A subacute course makes simple viral pericarditis less likely, more workup needed. A large effusion carries tamponade risk. Echo and monitor closely. Tamponade physiology itself is a hemodynamic threat. That's the drainage pathway. No response to NSAIDs after about a week suggests something complicated or refractory. Escalate the workup. And immunosuppression, anticoagulation, or trauma in the picture. Admit, because the underlying cause could be dangerous. Let's talk causes, because NBME loves testing them. Viral or idiopathic, the classic, most common outpatient pattern. Post-MI, either early fibrinous pericarditis or the later Dressler syndrome. Uremic, think dialysis patient, and the fix is intensifying dialysis. Autoimmune, lupus, rheumatoid arthritis. And malignancy, TB or purulent causes. Think large or recurrent effusions. NBME Pearl. Simple viral pericarditis acts simple. The high-risk features are exactly where Step 2 hides the real diagnosis. Timing is everything after an MI. 1 to 3 days out, early fibrinous pericarditis, and here aspirin is preferred. Weeks to months later, that's Dressler syndrome, an autoimmune process treated with NSAID or aspirin plus colchicine. But chest pain after an MI plus hypotension and JVD? That could be tamponade from a free wall rupture. That's an emergency, not just pericarditis. And a new murmur with pulmonary edema points to a mechanical complication, papillary muscle rupture or a VSD, different animal entirely. Plot twist time. When pericarditis symptoms come with troponin elevation, you might be dealing with myopericarditis. If the troponin is very high, or there's LV dysfunction, That signals real myocardial involvement. Echo assesses ventricular function, and cardiac MRI can clarify the inflammation pattern. Exercise restriction becomes especially important here. NBME-Pearl. Mild troponin elevation can just happen, but LV dysfunction? That makes it a completely different game. And just when you thought you were done, it comes back. Recurrent pleuritic positional pain after a prior episode. Treat with NSAID or aspirin plus a longer colchicine course, and try to avoid steroid dependence when possible. If it's acting atypical, evaluate for autoimmune disease, TB, or malignancy. In real life, there are fancier specialty therapies, but for step 2, they usually just want your colchicine logic. NBME-Pearl. The pericardium can have sequel energy. Colchicine is the anti-sequel drug. Chapter 3. Cardiac Tamponade. Fluid, under pressure. The heart is being hugged by a python, and pythons do not let go. Here's your vignette. Hypotension or frank shock. Elevated jugular venous pressure. Muffled heart sounds. Pulsus paradoxus. Dyspnea, tachycardia, and a narrow pulse pressure. NBME-Pearl, and I want you to really hear this one. Tamponade is not wait for morning rounds medicine. This is act now. Let's break down the mechanism. A large pericardial effusion accumulates rapidly from malignancy, post-cardiac surgery, trauma, pericarditis, or anticoagulation. That fluid raises intrapericardial pressure and compresses the right atrium and ventricle, impairing diastolic filling and reducing venous return. The consequence is obstructive shock, low cardiac output, hypotension, end organ hypoperfusion. Clinically, you're looking for Beck's triad and more: hypotension, JVD, muffled heart sounds, tachycardia, and pulsus paradoxus. On echo, look for diastolic collapse of the right ventricle. Key point: this requires rapid accumulation or a large volume. It's life-threatening, and you need to recognize and act quickly. Let's actually understand pulsus paradoxus, not just memorize it. It's an exaggerated drop in systolic blood pressure during inspiration, more than 10 millimeters of mercury. Here's the chain. Inspiration increases venous return to the right heart. The right ventricle expands. That expansion pushes the interventricular septum leftward. That septal shift decreases how much the left ventricle can fill, and so systolic blood pressure falls more than 10 during inspiration. You'll also see this in severe asthma and severe COPD, not just tamponade. Takeaway: it's caused by more right heart filling and less left heart filling, all thanks to that shared septum. Echo is your best friend here. Standard views: parasternal long axis, parasternal short axis, apical four-chamber, subcostal four-chamber. For pericardial disease specifically, you're hunting for pericardial effusion, right ventricular diastolic collapse in tamponade, and septal bounce in constriction. Why echo? It's non-invasive, widely available, no radiation, gives you real-time information, and it is genuinely the first lone test for evaluating pericardial disease. Suspected tamponade. Assess stability immediately. If they're unstable, in shock, with tamponade physiology, emergent pericardiocentesis, full stop. If they're stable but the effusion is concerning, get an urgent echo and manage under close monitoring. IV fluids can be a temporary bridge if they're hypotensive, but avoid delaying drainage for a CT scan in an unstable patient. That CT can wait, the heart cannot. Only once the heart can actually fill again do you go treat the underlying cause. Pericardiocentesis is the urgent procedure for tamponade and large symptomatic effusions. The most common approach is subxiphoid, directing the needle toward the left shoulder at roughly 30 to 45 degrees. Echo guidance is strongly recommended. The ultrasound confirms the effusion and guides the needle safely. How it works: remove the fluid, relieve the compression, and hemodynamics improve. Use aseptic technique, local anesthesia, continuous monitoring, and always send that fluid for analysis: cell count, protein, glucose, culture, cytology. And keep watching for complications: arrhythmia, bleeding, organ injury, infection. What causes tamponade? Trauma or a procedure. Sudden hypotension after chest trauma or a cath, that's emergency drainage. Malignancy, recurrent or bloody effusion with weight loss, diagnostic drainage plus an oncology workup. Uremia, advanced renal failure or dialysis, intensify dialysis, drain if needed. Aortic dissection, tearing, chest pain with an aortic regurgitation murmur, that's a surgical emergency. And infection or TB, fever, night sweats, immunosuppression, drain, culture, and start antimicrobials. Chapter 4. Pericardial effusion. Fluid can be quiet until it isn't. Effusion is the quiet middle child of this whole family. It can be totally asymptomatic or cause dyspnea, chest discomfort, or full-blown tamponade. Echo tells you the size and, more importantly, the hemodynamic effect. You might see low-voltage ECG or electrical alternans with a large effusion, and a water bottle heart silhouette on chest X-ray suggests a large chronic effusion. Management depends entirely on stability and the suspected cause. NBME Pearl. Volume matters less than pressure, and how fast that fluid accumulated. See an effusion on imaging? First question: is there tamponade physiology? If unstable, urgent pericardiocentesis. If stable and small, treat the underlying cause and follow up with echo. If it's large, symptomatic, recurrent, or looks suspicious, go ahead and drain it for analysis. And whenever there are clues pointing to malignancy, infection, TB, uremia, or autoimmune disease, go find that cause. When do you drain purely for diagnosis? Tamponade. It's both therapeutic and diagnostic, triggered by shock or high JVP. Suspected purulent infection. You need cultures and source control, prompted by fever or a toxic-appearing patient. Suspected malignancy. Cytology, prompted by weight loss or a recurrent bloody effusion. Suspected TB. Microbiology, ADA, or PCR depending on setting, prompted by night sweats or known exposure. And a large or recurrent, unexplained effusion. Because honestly, it keeps coming back like a bad ex. Time to find the cause. Chapter 5. Constrictive pericarditis. The pericardium turns into a stiff jacket. Very rude. Classic vignette: chronic or subacute right-sided heart failure. Ascites, edema, hepatomegaly, fatigue. Elevated JVP with a Kussmaul sign, meaning it actually rises with inspiration. A pericardial knock on exam. and a history of TB, radiation, cardiac surgery, or recurrent pericarditis in the background. NBME Pearl. Right-sided failure plus a preserved ejection fraction plus an old pericardial insult. That combination should make you think constriction. Let's look at the anatomy. The pericardium becomes thickened, rigid, fibrotic, sometimes calcified, from chronic inflammation and scarring. Worldwide, TB is the leading cause. Elsewhere, it's more often prior cardiac surgery, radiation therapy, or idiopathic and autoimmune processes. Mechanically, that stiff, non-compliant pericardium encases the heart and limits its normal expansion during diastole, impaired filling of all four chambers, leading to elevated systemic and venous pressures, and ultimately right-sided heart failure. Clinically, elevated JVP, Kussmaul sign, pericardial knock, ascites, edema, hepatomegaly. And the signature physiologic finding? Septal bounce or ventricular interdependence. The septum shifts dramatically with respiration, and diastolic pressures equalize across all chambers. Let's decode each finding. Kussmaul sign. JVP rises with inspiration because the right heart simply can't accept more venous return. Pericardial knock, an abrupt halt to ventricular filling, heard as an early diastolic sound. Ascites and edema, systemic venous congestion that, fair warning, can look exactly like liver disease. Preserved ejection fraction. The squeeze is fine. It's the filling that's the problem. And pericardial calcification, a chronic scarring clue you'll spot on chest X-ray or CT. This is a big one. Constrictive pericarditis versus restrictive cardiomyopathy. In constriction, the problem is outside the heart. The pericardium itself is thick and rigid, while the myocardium underneath is usually just fine. You'll see chronic scarring, ventricular interdependence, septal bounce on echo, equalized diastolic pressures, a pericardial knock. And here's the good news. It's potentially curable with pericardiectomy. In restrictive cardiomyopathy, the problem is inside the heart. An infiltrative or depositional disease like amyloidosis, sarcoidosis, hemochromatosis, or Fabry disease has made the myocardium itself abnormally stiff. You'll see biatrial enlargement, equalized diastolic pressures too, but no pericardial knock. And treatment targets the underlying disease, not surgery. Bottom line, constriction, fix the pericardium. Restriction, treat the disease inside the muscle. Workup sequence. Right-sided failure symptoms, high JVP, preserved EF. That's your trigger. Transthoracic echo looks for septal bounce or a constrictive filling pattern. CT or cardiac MRI checks for pericardial thickening, calcification, or inflammation. Cardiac catheterization comes in if the diagnosis is still unclear. And always evaluate for the cause: TB, prior surgery, radiation, malignancy, or autoimmune disease. For mild or transient inflammatory constriction, anti-inflammatory therapy may actually help. Volume overload, cautious diuretics for symptom relief. Chronic, severe constriction, pericardiectomy is the definitive answer. And always treat the underlying cause: TB therapy, malignancy care, autoimmune control. And please, do not call this cirrhosis without checking the neck veins. Please. Chapter 6. Differentials and Traps. This is exactly where Step 2 steals your points. So today, we steal them back. Two obstructive shock lookalikes that examiners love to swap: cardiac tamponade and tension pneumothorax. In tamponade, fluid fills the pericardial sac. You get Beck's triad, pulsus paradoxus, but the lungs stay clear and breath sounds are equal on both sides. In tension pneumothorax, air fills the pleural space and can't escape. You lose breath sounds on the affected side, get hyperresonance, JVD, hypotension, and the trachea deviates away from the affected side. Immediate treatment couldn't be more different. Pericardiocentesis for tamponade, needle decompression, then a chest tube for tension pneumothorax. Simple rule: tamponade is a problem in the sac. Treat the sac. Tension pneumothorax is a problem in the space around the lung. Treat the space. Both are true emergencies. Now the other classic mix-up: tamponade versus constrictive pericarditis. Time course: tamponade is acute, hours to days. Constriction is chronic, months to years. Blood pressure: low with a narrow pulse pressure in tamponade versus normal or low normal in constriction. Pulsus paradoxus: present in tamponade, usually absent in constriction. Echo hallmark: RV diastolic collapse in tamponade versus septal bounce in constriction. Pericardial fluid: a large effusion in tamponade versus none or minimal in constriction. And treatment: urgent pericardiocentesis for tamponade, pericardiectomy as the definitive fix for constriction. Remember it this way: tamponade is a pressure problem. Act fast and decompress. Constriction is a stiffness problem. Think constrict. Think surgery down the line. Let's name the traps directly. Diffuse ST elevation does not automatically mean STEMI. Troponin can be mildly elevated in plain pericarditis. Tamponade means you do not wait for a CT if the patient is unstable. Steroids are not routine first-line therapy for pericarditis. And constrictive pericarditis can absolutely masquerade as liver disease. NBME Pearl. They love confusing the pericardium with an MI, a PE, cirrhosis, and plain old panic. Etiology clue drills. Advanced renal failure, think uremic pericarditis, intensify dialysis. Cancer with a recurrent bloody effusion, think malignant effusion. Drainage plus cytology. Fever and a toxic appearing patient with effusion, think purulent pericarditis. Drainage plus antibiotics. Night sweats and known exposure, think tuberculous pericarditis. Start the TB workup. And lupus-type symptoms, think autoimmune pericarditis. Treat the inflammatory disease. Disposition time. Low-risk acute pericarditis can absolutely go home with close follow-up. Admit anyone with high-risk features: fever, a large effusion, tamponade, immunosuppression, anticoagulation, or trauma. Tamponade or an unstable effusion needs a monitored or intensive care setting. Constrictive pericarditis gets a cardiology referral, with surgery if it's chronic and severe. And you'll follow symptoms, CRP, and echo as appropriate. NBME Pearl. Stable, simple pericarditis may go home. A shocky pericardium gets a room upstairs. Chapter 7. Challenge Cases. Short vignettes, fast recognition, pure Step 2 reflexes. Let's see if you'd pass. Case 1. A 25-year-old, recently over a viral illness, has sharp chest pain, worse lying down, better leaning forward. ECG shows diffuse concave ST elevation with PR depression. What's the move? Acute pericarditis, NSAID or aspirin plus colchicine if the patient is stable. And the trap everyone falls for. Do not activate the STEMI pathway just because the ST segments look dramatic. Drama is not diagnosis. Case 2. A cancer patient with dyspnea suddenly becomes hypotensive with distended neck veins and muffled heart sounds. Bedside echo shows a large effusion with right-sided chamber collapse. The move? Cardiac tamponade. Urgent pericardiocentesis. No delay. The trap? Do not wait for a CT scan in an unstable tamponade. That patient needs the needle now, not the scanner. Case 3. A patient with a history of mediastinal radiation presents with ascites, edema, an elevated JVP that rises with inspiration, and a pericardial knock. Ejection fraction is preserved. The move? Constrictive pericarditis. Echo, CT, or MRI to confirm, and pericardiectomy if it's chronic and severe. The trap? Do not call this cirrhosis before you've checked the neck veins. Case 4. 3 weeks after a myocardial infarction, a patient develops fever, pleuritic chest pain, and a friction rub. The move? Dressler syndrome. Aspirin or an NSAID plus colchicine, depending on the clinical context. The trap? Timing is everything. Weeks to months after an MI, this is autoimmune pericarditis, not the early fibrinous kind. Case 5. A dialysis patient with chest pain and a friction rub, but no regional STEMI pattern on ECG. Labs confirm severe renal failure. The move? Uremic pericarditis. Intensify dialysis and evaluate for effusion or tamponade. The trap? Do not treat this as simple viral pericarditis and just sending them home. Uremic pericarditis needs its dialysis fixed. Case 6, our final one. A stable patient with pleuritic, positional pain, and only mild troponin elevation. But the echo shows new left ventricular dysfunction. The move? Suspect myopericarditis, cardiac MRI or echo monitoring, plus exercise restriction. The trap? Mild troponin elevation can just happening in pericarditis, but ventricular dysfunction changes the whole Montum plan. Nice work if you got all 6. Final chapter, rapid review. These are the last slides before your question block. Let's lock it all in. One more pass, fast. Pleuritic plus positional pain, acute pericarditis, ECG, then NSAID or aspirin plus colchicine, shock, JVD, and muffled sounds, cardiac tamponade, echo if you can get it, then pericardiocentesis. Right heart's failure with Kussmaul sign, constrictive pericarditis, echo plus CT or MRI. A friction rub 1 to 3 days post-MI, early fibrinous pericarditis, aspirin preferred, and a rub goods after in Kevin About and CD, Chrysler syndrome. 10-second recall, go. Acute pericarditis, pleuritic, positional, diffuse ST elevation, PR depression. Treatment, NSAID or aspirin plus colchicine. Avoid routine steroids. Tamponade, hypotension, JVD, muffled sounds, pulsus paradoxus. Treatment, pericardiocentesis if unstable. Constrictive, right heart failure, Kussmaul sign, pericardial knock. pericardiectomy if chronic and severe. And the pearl to end all pearls. If the sac is inflamed, medicate it. If it's squeezing, drain it. If it's scarred, cut it. Here's your final decision tree, the whole lecture in one flowchart. Any pericardial clue. First, classify the syndrome. Chest pain better leaning forward, acute pericarditis. Shock or high JVP, tamponade, straight to pericardiocentesis. Chronic right heart failure with Kussmaul sign or a pericardial knock, constriction. Diffuse ST elevation with pericarditis clues does not mean an automatic trip to the cath lab. And any high-risk feature. Admit and go find the cause. And that's our source backbone, the uploaded pericardial disease review for Step 2 scope and traps, ESC guidance for treatment logic, ACC imaging guidance for the echo first approach, and clinical references like the Merck manual for classic vignette language. Everything you just heard is built on that foundation. And that's the pericardium, start to finish. Tiny sac, huge drama. Inflamed, you medicate it. Squeezing, you drain it. Scarred, you cut it. Remember your 3 lanes: pain, pressure, or plumbing. Get that fork right, and the rest of this topic basically solves itself. Go get some rest. Go crush that question block. And give that poor little sac some respect. It's been through a lot today.